packed agenda today, and hopefully it will be something that would everybody will enjoy. And as first item for today, we've got an introduction in scene setting from Dr. Ong So, who is our regional neonatal clinical lead. Over to you, Ong.
Thank you so much, Shan. Hope everybody can hear me. Yes, thank you for inviting me. And as Shan said that I was asked to do the introduction, especially from the, I guess, from the neonatal perspective. And we all know that the World Prematurity Day is always 17th of November. And this year theme, as Sean said, is the Give Preterm Babies a Strong Start. I guess through mom and also to the baby for a hopeful future. And I think Shannon and I use the same picture here, which I really like, the tiny little socks, 1 in 10, which is clearly seen in both the local and worldwide data showing 1 baby in 10 is born premature worldwide. And those two organizations were the founders of the World Prematurity Day. Next slide, please, Charlotte. Thank you. Yeah, I think that there's a few important points I would like to mention. One is globally, over 13 million babies are born prematurely each year, which equate to 1 premature birth every 2 seconds, which is really a common occurrence. And sadly, tragic deaths occurring every 40 seconds among these vulnerable babies. Roughly 1 in 10 babies sadly died born prematurely. And it started 14 years ago. And the key thing is there are the about 3 or 4 main aims of having this World Prematurity Day. Talk about raise awareness about premature births, and then importantly, impact on the babies and families. And secondly, to promote measures to prevent preterm births. And then thirdly, to make sure that these babies have the better outcomes. And emphasizes on importance of prenatal care, again, locally and also globally, and also to look at and practice medical advancements, and then the support to the families dealing with premature births. I think in the UK, Southeast, locally, we are doing more and more, especially for the third birth as well. So for this webinar, I think the 4 topics are really fitting with those aims. Smoking in pregnancy, which is we know that really important, especially for these preterm babies in maternal smoking. Prem 7, which I got a slide to show you about the cultural awareness, and the cervical length, which is really good measure to predict preterm birth. And then genetic is coming more and more important. So genetic risk equality project, I think so. I think all of these 4 talks will fit in with the aim of the World Prematurity Day. Next slide, please, Sean. So I just want to talk a little bit about the Prem 7 Plus as the regional update. Most of you will be familiar with this important perinatal optimization project, which is a key initiative in maternity and neonatal services across Southeast. It comprises the 9 evidence-based interventions, which is showing in the diagram next to it, which directly optimize the outcomes for the babies born prematurely. So in Southeast, 3 years ago, we started as a Prem 7, so 7 interventions. And then following year, 2023, we added on the diagram 2 measures, caffeine and respiratory management. I know some units do more than that, so that's why we decided to change to Prem 7 Plus. It is a regional-wide project working with the 2 ODNs, KSS and Thames Valley Wessex, 3 health innovation networks, and then also with the 6 LMNSs across Southeast. It is a really good example of collaborative approach between maternity and neonatal services. I just put a bit of statistics for you in the Southeast in 2023-24 over a year, 80,000 live births, and out of that, just over 6,000, which is 7.6% of total live births, are born prematurely under 37 weeks. And most importantly, among them, 380 babies. So this is the 0.5% of total live births were born extremely prematurely under 28 weeks. So these are the babies who will be most beneficial from this Prem 7 Plus project, and also the other the interventions that you're going to talk about it in that webinar later. Next slide, please, Charlotte. So lastly, I just want to share with you about a quote that, so I was interviewed about a week ago, one of my ex-patients who is now 22 years old, and she is studying journalism in one of the very top university, being born as a twin in 25 weeks, so she's done really well. And so she interviewed me, and she now published the article she sent to me yesterday. And the quote I really like, kind of conclusion part of her article is that World Prematurity Day is all about raising awareness. But for me, it is also about giving thanks to the doctors, nurses, and families of the neonatal units who continue to fight for tiny lives every single day. On this day of World Prematurity, take a moment to celebrate the strength of premature babies, their families, and the incredible people who care for them. Because in the world of neonatal care, every little counts, and little one counts most of all. So thank you so much, and I hope you enjoy the webinar. And thanks, Sean and Charlotte, for inviting me.
Thank you. Next slide, please, Charlotte. Our next speaker is Heidi Croucher from the Smoke Free Project in Dorset Council, and also tobacco dependency midwife, and Matilda Allen from OHID, who are going to talk to us about prenatal health and smoking in pregnancy in the Southeast. Thank you. Over to you, ladies.
Thanks very much. So I'll kick us off, and then I'll pass over to Heidi once we're kind of about halfway through. So can we move to the next slide and next one again? Thank you very much. Quick data note. So I'm going to show you tons of data. The slides will be shared, so you'll be able to look at it in a bit more detail. Obviously, as we're aware, some of these kind of use small numbers, so just a bit of caution about the data. But broadly, I think the patterns that we see and the overall kind of epidemiological picture is valid. So next slide. And again, right. Okay, so most of the data that I'm going to show you is regional or local, but I think it's worth just reminding ourselves about some of the kind of key inequalities, and we see this in the national data. So this is, as you're all probably familiar with, stillbirths and neonatal deaths, and the two inequalities that we see here are inequalities by deprivation and inequalities by ethnicity. And as we know, we see really clear inequalities, so much higher rates of stillbirth and neonatal death for the most deprived areas, the kind of lowest income areas, and then also for Black and Asian mothers. Next slide, please. When we look regionally, we see a lot of those inequalities replicated in our region as well. So if you look at the kind of bottom left of these bar charts, that shows the inequalities in stillbirth rate by ethnicity. And you can see a much higher rate there for Black or Black British ethnicity group compared to some of the other ethnicity groups. And then also some other inequalities and higher rates generally for younger and older mothers. And then also some inequalities by the deprivation profile as well. Next slide. This is just kind of showing a little bit more detail on those inequalities by ethnicity. And I should have said pop questions in the chat, but also we'll try and leave some time at the end. And I can see there's already a question about how preterm birth rates in the Southeast compare with national. This is stillbirth rate, but rather than preterm birth, but it gives an indication of some of the differences. So for all of the other ethnic groups, we actually have a lower rate than the national. So on this, the kind of light green bars that have the numbers on are the national, and then the light grey bars are the Southeast. So you can see that we have a lower rate for every ethnic group apart from Black or Black British, where we have a higher than the national rate. Next slide. So we're mainly going to talk about smoking. I'm just going to very quickly show you 2 bits of data about healthy weight and folic acid as 2 other kind of indicators of prenatal health that are really important. And as we know, both healthy weight and folic acid, here I'm focusing on preconception, so women taking folic acid before they become pregnant. Both of those are associated with preterm birth and stillbirth. Next slide. So here we can see obesity. So this is the proportion of women who are overweight or obese at booking appointment. And this shows over time. So from the dark blue is 2022, and then the dark grey is 2023, and then the light grey is 24. So you can see in each of the kind of areas within the Southeast an increase in obesity at booking appointment over time. And overall, half of women in the Southeast are overweight or obese at booking. Next slide. On folic acid preconception, what we see is generally dropping rates in a lot of areas and overall much lower than we kind of need it to be, although there are some issues with the data quality there. Next. I'll hand over to Heidi, who will talk a bit about smoking.
Thank you. So I do recognise some people on the call, so it's lovely to see you again. My name's Heidi and I'm the lead smoking and pregnancy midwife, NHS England prevention team, and I know I've been supporting a lot of you around implementing your smoke-free pregnancy services. So smoking in pregnancy does still matter, even though we have made really good headway since we launched the long-term plan in 2019, and we've actually nationally halved our smoking at time of delivery rates. We still have a lot to do. And this is really just a reminder that smoking is still that leading modifiable risk factor in terms of those poor health outcomes, not just for the pregnant people, but also for their families and their children. So by modifiable, it's something that we can still make a big difference with. And smoking in pregnancy, you know, is still causing those miscarriages, so significant risk of miscarriage, premature birth, babies being born with low birth weight and heart defects, sadly stillbirth, 47% more likely to have a stillbirth. If you smoke during your pregnancy, 3 times more likely to experience sudden infant death. You know, and this is all really tragic stuff and very, very sad for families when they experience this. Next slide, thank you. So the impact of smoking, both on the pregnant person, their family, and also our NHS, is huge. As you can see, the cost there, 20 million to 87.5 million annually. It's costing our healthcare. I've already talked about those complications, which can have a huge impact on a family and on subsequent pregnancies. Those long-term effects for children when they are either born to a mum who's smoked in her pregnancy or are growing up in a really smoky home. So it's not only around tackling the element of reducing or becoming a smoke-free pregnancy, but a smoke-free home too. And the financial burden on families is huge. And we know that the younger women from deprived backgrounds are more likely to smoke and be exposed to secondhand smoke, and significantly higher risk of infant mortality in these groups. Thank you. Next slide. So what did we do about it? I remember as a smoking and pregnancy midwife, being the launch of the first Saving Babies Lives Care bundle. So at that time I was leading a smoking and pregnancy service in Dorset. And it was like, wow, all of a sudden we have something to really drive down are stillbirth rates, and element 1 was smoking in pregnancy, and it was in the first bundle. And then as we've seen a couple more Saving Babies' Lives care bundles come through, element 1 is still supporting families to become smoke-free. And if you just move on to the next slide, and this bundle came out to really drive down and halve the stillbirth rates by now. And this work is being evaluated, and we've just seen the evaluation for the second version of Saving Babies' Lives. But it was really important for us within the national team to align the long-term plan work with Saving Babies' Lives. And it was really focusing on what the evidence told us was that it's that in-house opt-out model that really does make a difference. It's that universal carbon monoxide testing at booking and at 36 weeks on all pregnant people. And then those high-risk groups, which were evidenced in the latest NICE guidance, at all antenatal appointments. So if they have an elevated carbon monoxide reading or if they are a smoker. And that speedy opt-out referral through to an in-house stop smoking service at the booking appointment, where they're seen and supported throughout their whole pregnancy by a treating tobacco dependency advisor, and have really quick access to nicotine replacement therapy. And if they relapse, get back on that journey again and support them through not only to the end of the pregnancy, but also into the postnatal period. Thank you. Next slide. And I think nationally now we have around 97% of our maternity units across the country offering an in-house opt-out service, which is brilliant. And that's work that I've been really involved in supporting with my national hat. And what difference does this make? The difference is huge. So if you just move through these bullet points, so just keep moving them through. So it can be really hard for somebody to stop smoking. And we know that if they're coming into a pregnancy journey smoking, it's because they probably tried many times and failed, and really need that additional support. That I would imagine they're quite complex, have high risk elements to their pregnancy, some safeguarding issues. So it's really important that we do give them the support. And with this support, they're 4 times more likely to become smoke-free. It's around the in-house service being seen as part of that journey, that maternity journey. So a seamless referral through to the in-house team. Part of that, it means that the treating tobacco dependency team can engage with all the professionals working and supporting that pregnant person through their pregnancy journey. It's that continuity of support by somebody that they can trust, and that really regular intensive contact from the trained specialist smoking and pregnancy support workers or midwife. And quite often what will happen is it will be that direct supply of nicotine replacement therapy or vapes to the pregnant people, and possibly significant others if that's what the model looks like at that particular trust. Next slide. We know that the biggest barrier to somebody quitting smoking is if their significant others still smoke, to people that they live with, their partners. So it's really important to not only support pregnant person through their smoke-free journey, but also people around them that smoke. Thank you. Next slide. Next slide, that's fine. And then on top of all this amazing stuff that's already going on, and you can just click this through as well, we have the Smoking in Pregnancy Incentive Scheme. So this is a national scheme that was based on some really good research. So when I was leading a smoking and pregnancy service in Dorset, I was part of the CPIP trial, which was to see if incentives really did make a difference, and they do, which is why OHID launched this scheme earlier this year. They're just now expanding the incentives to go out and offer them to significant others, and it's looking like it's going to continue also through next year. But it's a standardized, equitable service that really does increase not only engagement but quit rates when we use an incentive. And you can see obviously the breakdown of what a person gets throughout their pregnancy, but it's a total of £400. Thank you. I think it's back over to you.
Thanks very much, Heidi. So yeah, I'm just going to show you some further data about these services in the Southeast. So if we move on to the next slide. So this is the proportion of women who are smoking at booking appointment and then also at time of delivery for each of the areas, the local authorities within the Southeast. So what you can see here is a clear variation in how many women are smoking at booking appointment, so kind of double the rate in Isle of Wight compared to Slough, for example, but also a really clear variation in how many women are quitting. So the difference between the kind of blue bar and the grey bar is how many women are able to and supported to quit over the length of their pregnancy. Next slide. And that just shows that difference. So you can see, for example, in West Sussex, that is the biggest percentage difference. So the biggest proportion of women who are supported to quit over the course of their pregnancy. So you can see that that varies. And that's partly down to population demographics and the rates in the first place, but it's also partly due to the services that are in place and how effective they are at supporting women to quit. Next slide. So this shows not just for maternity, but also for some other kind of key tobacco dependency services in the Southeast, the coverage that they are achieving. So what you can see here is maternity is in the kind of pinky colour. Generally, the coverage is much higher than in the other tobacco dependency services, which is great, but still a couple of areas where we need to kind of do more to get it up to 100%. And that's counted as reporting 10 or more referrals. Next slide. This shows kind of what happens across the Southeast when women are referred into the tobacco dependency services and really kind of where they're lost. So at what point are women not kind of being supported into the next stage of their quitting journey? So at the beginning, you can kind of see all of those people who are identified at smoking. And then at every step of the pathway, how many women are kind of lost to further follow-up or not kept within the service. So at the beginning, there's a certain proportion of women, about 26%, who aren't referred to the service in the first place. Then there's some who aren't seen. Then there's some who don't set a quit date. And then there's some who don't manage to quit. I mean, I think the point here is by the end, the proportion of women who aren't quitting, yes, those people need to be supported to quit, but also much earlier in the pathway, we can increase the number of women quitting by increasing the number who are successfully referred in and seen by the services. Next slide. And this just shows some of the inequalities as well. So some of the kind of demographic inequalities. This is focusing on deprivation as a kind of proxy indicator for poverty and low income, basically. So what we see in the first bar chart on the top left is, as we know, women from the most deprived quintile, the most deprived 20% of areas, are more likely to be identified as smokers. So that's kind of 22%-ish of those women compared to only 9% or so of those least deprived areas. But when we look at the other bar charts, what we see is that they are not necessary. There is a kind of inverse inequality in that the women from the areas that are least deprived are more likely to be referred to the service, more likely to be seen, and then more likely to quit. So it's those kind of inequalities that we need to be thinking about to reduce some of the inequalities in outcomes. And I guess to kind of relate this back to the kind of the original theme and some of the data at the beginning, to reduce some of those inequalities in outcomes in terms of prematurity and stillbirth. It's kind of tackling these inequalities that are really important. Next slide. So here we've just got a summary, and this is just the kind of the things that we've showed you over this presentation. So we know that there are inequalities in pregnancy outcomes, and we also know that prenatal health is really important. So we've talked a lot about smoking, but also not to forget some of the other indicators of prenatal health, like obesity and folic acid. As Heidi has told us, smoking is the leading modifiable risk factor, and she talked a bit about saving babies' lives in that it provides a maternity-led treatment-focused pathway and how important that is. We know that there's geographical variation in the proportion of women who are smoking when they book in the Southeast, and then the proportion who manage to quit or are supported to quit over the length of their pregnancy. And we also know that the coverage of tobacco dependency services, although generally high in some areas, just needs to kind of cross over into that threshold of effectively and consistently referring women into the service. And then finally, we know that at each stage of that pathway, there are opportunities to improve and that there are inequalities in outcomes of those tobacco dependency services. And that's really important as well. So I'll stop there. If anyone has any questions for me or Heidi or both of us, feel free, put up hands. And as I said, we'll share the slides. So all of that, the many graphs and data, you'll be able to kind of look at in your own time as well.
Thank you, Heidi and Matilda. And for those who asked about the premature birth rate in the Southeast, Matilda has actually put some data into the chat if you want to see that there. Thank you. Any questions? I can't see any hands up at the moment. No? Well, thank you. And it's really been great to hear something about the differences geographically across the Southeast, as well as the impact of the inequalities. It's been fascinating to see the actual data for the Southeast. Thank you. And any more questions, feel free to put them in the chat. I'm sure they'll be answered during the course of the webinar. Okay, thank you. Next slide, please. So our next presentation is from Sana Shahid from the Surrey Minority Ethnic Forum, who will be talking to us about the Prem 7 cultural awareness training that they've put in place in Surrey. Thank you, Sana.
You're very welcome. Very good morning to all of you. So I'm Sana Shahid. I'm the Senior Engagement and Development Officer at Surrey Minority Ethnic Forum. Next slide, please. We have been running different projects, including baby steps for the past 4 years for NHS Code 20+ by Community Correct program. So there have been various projects, including public health research, many hands, baby steps, and also we're continuing to run some research that impacts the health in minoritized communities. The feedback was shared with the professionals. They needed to be more culturally aware. And Surrey Heartlands took all the recommendations on board and commissioned us to run these trainings. Next slide, please. Thank you. So as you can see in this slide, that pregnant women and birthing people from ethnic minority communities are more likely to have preterm births in Surrey Heartlands. And women and birthing people have reported cultural insecurity, religious insecurity, and racism in their care from health professionals from maternity and neonatal services. Women and birthing people are unsure of how to access services, so the language is complex and medical, some of which cannot be translated into their first language, as a term does not exist. There are terms that they do not exist, and cultural sensitivities exist around women's health. Lack of cultural awareness can create barriers to access as well. Surrey has a number of hotels for refugee asylum seekers, women and birthing people seeking asylum who have experienced trauma in their country of origin or journey to the UK. And women and birthing people have asked for greater cultural awareness from staff and trauma-informed compassionate care. A lot of women who have had their 2 children before and have had their 3rd one in the UK have been attending our baby step sessions. And so many of them are so unaware about so many things. They have no idea about even a basic term like pelvic health. But they have been getting awareness, and we took them step by step from registering them at primary care to taking them to the safe deliveries and follow-up checks and good care of their children and their own health as well. Next slide, please. This has been our draft delivery pattern. So Surrey Minority Ethnic Forum, which we call SMEF, is a race equity charity based within Surrey. And we work with over 60 local race and ethnic minority charities across Surrey Heartlands, providing a collaborative voice to represent the diverse ethnic minority and displaced communities across Surrey. So we have delivered cultural awareness trainings online and in person to the listed areas, as you can see in the slide. If you want, I can share the slides with you as well. Next slide, please. Our ratings have been 4.6 out of 5. And as you can see, the feedback, I can read out some of it, which is somebody shared that I'm so glad I joined. At times I felt embarrassed about my lack of awareness, but one of our facilitators put everyone at ease. So many conversations with and about NICU families popped into my head where their reactions and sometimes indifference now make sense. And I really hope that our team can do better to build mutual respect and trust with all our families on NICU. The usual feedback that we get is that the facilitators share their personal stories and the differences that they have faced in their lives, facing different lives in different cultures, having lived different cultural experiences, which helps them in getting better understanding, and they can share their concerns and queries very openly in understanding of the situation. Next slide, please. So these are our next steps. The reporting of content, the number of attendees, and feedback, which is regularly given to NHSC team. Successfully, the funding has been secured for 6 further SMEF cultural awareness training sessions for health, social care, VCSE, and students across Surrey system for 2025 to 2026. Part of the ICB Commissioning Intentions Health Inequalities Equity in Action program for 2025 and 2026. The aligned projects are successfully secured funding as a part of Equity in Action for Women's One-to-One Community Mental Health Counseling to support women, including those in perinatal period from ethnic minority communities and inclusion health groups in accessing mental well-being support and support referrals into Tier 3 services. The second one is funding for 4 health marketplace events to be held in our communities as a part of Equity in Action, providing access to health education services and health checks. They will include MNVPs and women health clinicians. And the third one is continuation of SMEF baby steps groups, supporting women and birthing people from ethnic minority communities and inclusion health groups. Funding from Community Foundation for Surrey until 2028 and expansion in 2025-26 to include women health groups providing women's health education and well-being support as a part of ICB Equity in Action funding. So that's how we are planning to go ahead. I'm open for any questions and answers. Thank you.
Thank you, Sana. Any questions? If you pop in chat or raise a hand.
Very welcome.
Thank you. I wondered, Sana, whether you'd just like to describe what happens at one of the training sessions that would be helpful for the group.
Sure. So the training that we run is designed across different cultures. We share the cultural statistics also, sharing the ethnicities and the percentages of where they exist more. And then we talk about the cultural dimensions that vary across the globe and how there are certain concerns that we discuss in our in the cultural awareness training while delivering it. There's a power distance dimension to it. Of course, there are language barriers as well. There's means of communication. There are many other dimensions that we talk about, the cultural aspects, which help the caregivers or the clinicians understand the sort of understanding people have from other cultures and why is the distance existing, or why are they behaving a certain way, or why do they want a certain type of response. So around those lines, we deliver the cultural awareness training. I'm happy to share the slides of cultural awareness training, but we usually, it's a paid thing by SMEF. So I would like to keep it to ourselves unless we officially deliver it for someone.
Sure, I understand that. And there's a question in the asking, does this work happen anywhere outside of Surrey and Sussex or anywhere else? Have you delivered it further afield yet?
So yes, we have been delivering it across Surrey. Sussex, I'm not too sure about, but we can certainly consider delivering it but sometimes, you know, traveling is a bit of an issue. So we can certainly deliver it online if needed. But it has created a great impact. And I have heard it from clinicians themselves that, you know, they have a bigger and better understanding of how people are and how cultures are and how the cultural differences exist. So they are able to deliver better services that way.
Thank you. And I'm sure Emma can get in touch with you. Sasha, the question?
Hi, yes, thanks, Dana. I just wanted to come in just to say that the approach to this that's been taken in Surrey Heartlands has been phenomenal. I think that I do a lot around Prem 7+. So we've funded this year for Surrey Heartlands, and it's just touching on the approach. I know you mentioned there that it was moved to a hybrid rather than face-to-face, and I think that's really helped you be able to deliver this to more groups, and you saw all the groups there. It's not just around delivering this to the NICU or SCABU staff. This has gone so much further than that. So the ICB staff, the service user leads, the PAGs, a massive amount of management or, you know, leaders have been able to have this training too, which has and will be phenomenal in the feedback. And just touching on the Emma's question in the chat, so the projects that we've been able to fund this year have had an equity focus, but we've also chosen projects for Prem 7+, which have got potential scalability. So as when this Sana has finished delivering this, we will be looking at how we can scale these wider, hopefully across the southeast and potentially further, but that will come later once the work has finished. But yeah, thank you.
Thanks, Sasha. Any more questions? Oh yes, Charlotte.
Oh, thank you, Sana. Fantastic presentation. It's great to hear about the work that you're doing there. And thanks, Sasha, for adding that. I think that'll be really important to be able to scale up some of these projects. Sana, for those who are wanting to get in touch with you, I was just wondering if you'd be able to put up your contact details in the chat for people if they want to find out a little bit more about it. Thank you.
Sure, thank you.
Trish? You're on mute, Trisha.
Yes, thanks, Shannon. Great presentation. And yeah, we've actually all received this training. And it was absolutely fantastic. And what I have to say is we will actually link Shanna and the team up with Judy Smith who's also delivering the culture training, and getting in contact with the trust as well, because I think there's a bit of a combined approach they could probably do together with the staff. So because it was really beneficial. So thank you for all that work. Yeah.
You're very welcome.
Great. Thank you. Thanks again, Sana. Right. If there are no more questions, we'll move on to our next presentation, which is a pilot implementation of cervical length ultrasound education for obstetric and gynae resident doctors in the Thames Valley Deanery. And the presenters are Dr. Maria Ivan, Katie Hall, and Eileen Dudley. Thank you. Over to you.
Okay, so I'm just going to check and see that you can see my screen.
Yes, thanks, Eileen.
Great. So good afternoon, everyone, and thank you for inviting us to join the webinar today. I'm Eileen, and I'm the Maternity and Neonatal Safety Improvement Lead for the Trust in the Health in Thames Valley and Oxford network. And I'd like to invite my co-presenters, Katie and Maria, to introduce themselves, please.
I'm Katie. I'm the specialist preterm birth midwife, working mainly in Oxford University hospitals, but also regional lead for the Thames Valley region.
Thank you, Katie. And Maria?
Hello, my name is Maria Ivan. I'm one of the maternal fetal medicine subspecialty trainees here at Oxford.
So we're going to talk to you today about a pilot implementation of cervical length ultrasound education for obstetrics and gynaecology resident doctors in the Thames Valley Deanery. Just going to move my slide on. So we're going to take an approach. So we're going to talk through the background and rationale for our programme. We're going to look at the course design. We're going to talk through the logistics and the coordination of a programme like this. And we'll talk through some feedback and evaluation outcomes, and then we would love to talk to you in more detail and have some Q&A at the end. So I'm going to talk to you a little bit about the background and why this is an important piece of work. Other presenters have talked today about the association between preterm birth and morbidity and mortality. And so we know that it's the biggest single cause of morbidity and mortality for children under the age of 5. We know that it is more common in the global majority and that it's associated with deprivation and socioeconomic disadvantage. And those groups are much more likely to have a baby born too soon. Important drivers in terms of improving and focusing on improving outcomes for babies who are born too soon, you will see in the NHS Saving Babies' Lives Care Bundle, where element 5 talks specifically about preterm birth reduction by improving prediction and prevention. And we also know that the bundle talks about optimization of perinatal care, where preterm birth cannot be avoided. Now, this requires multi-professional perinatal working, and it also requires a system-wide approach. The SBC chart you can see on the right of your screen, that is an example of coordinated approach to an intervention, which has made a huge difference in terms of place of birth in the Thames Valley region. And it was a network-wide quality improvement project led by Professor Impey and Catherine Edwards. And it improved our place of birth rates from, rather shockingly, 50% of our babies were only born in the right place around 2012 to 2014. And we now have a rate of about 85% of our babies being born in the right place. We try to do better, but obviously we're quite proud of that. So I'd like you to meet the team and some photographs from some of our education days. So Maria, you've met here, and Katie, and our faculty also include Arpana Reddy, who's a fetal medicine consultant at Stoke Mandeville, so Bucks Healthcare. And we've got Professor Lawrence Impey, of course, who's a fetal medicine consultant at Oxford, and he's also the lead for our maternity and neonatal clinical network. Katie, who's a specialist preterm birth midwife, and then we have Lauren Little, who's a preterm birth midwife at Bucks Healthcare. Tara and I provide ongoing project support, and we have some excellent admin support. The days are very, very busy and very full on, and they require lots of coordination. So it's important to have a solid team behind us. I'm going to hand over to Katie, who's going to take us through the next few slides.
So our goal with this training was to train as many doctors as possible to be confident in performing cervical length scanning in an acute setting. So the idea being in triage max MAUs, if a woman comes in with symptoms of preterm labour, like a uterine activity, for example, they would be able to have a point of care bedside cervical length scan and use that in combination with the QUIP app to assess the risk of premature birth in that individual. And that means that we'll be able to identify the right women to be giving interventions to, such as steroids, admitting the right women, discharging the right women home, providing neonatal counselling, transferring the right women from level 2 centres to tertiary centres. So that was the overarching goal of the course. And then we decided that we were going to aim this teaching at doctors who are ST4 level and above. And the reason why is we decided they would probably have enough background in gynaecology scanning and basic scanning that they would really be able to use this training to build on those existing skills, but then also be able to take it back into practice and disseminate what they've learned to their colleagues as well. So that made it a much more sustainable approach and made sure that the trainees coming got the most out of the day. We, on our first day, decided we were going to have 4 trainees come in the morning and 4 come in the afternoon. But based on feedback from the trainees after that day, we decided to have all 8 trainees come in the morning and stay for the entire day, still doing the same number of scans, but then it also meant that they were able to observe another 3 scans each. So it really made their experience a bit better. We decided that we would have to do both a theory and practical approach to this training to make sure it was very useful and sustainable. and I'll talk about that on the next slide. We based this training both in the John Radcliffe Hospital in Oxford. We've got 4 of our days based there, and we've got 2 of them based in Stoke Mandeville in Buckinghamshire. And very importantly, we needed funding for this project. It's been one of the biggest things, and that money has come from the Health Innovation Oxford and Thames Valley. So we had 4 preterm birth specialists, the consultants and Maria, who's on the call today. Each of those specialists had their own room, and they each had 2 trainees with them. We split the day into 4 separate sessions, and in each session 3 participants would be scanned, and then the trainees would then swap around between the preterm birth specialists. So they got to experience all the wealth of knowledge and experience from each specialist, and all the nuances of scanning with each individual. So at the end of the day, if all 48 volunteers came, each trainee should have scanned 6 pregnant women. Did you, Maria?
Okay. Yes, thank you. So our primary focus was to maximise practical hands-on scanning experience. So that's the reason why I invited resident doctors who completed basic ultrasound scanning, and as well as the Fetal Medicine Foundation theoretical module on cervical assessment. And as Katie mentioned, we had a theory session followed by 4 one-hour practical sessions. And we felt that by giving the candidates the opportunity to both observe as well as practice the skill, they were able to rotate through different faculty members so they could experience a range of teaching styles. And our teaching framework focused on theoretical grounding and skill observations, and then we moved on to guided skill practice and directly supervised real-time scanning with immediate feedback. And after the course, each participant received an individualized learning plan in terms of how to consolidate their skills, whether through further preterm labour sessions and scanning, or we had some trainees who were undertaking special interest training modules that involved ultrasound scanning. So they were able to get a sign-off for cervical length scanning if they were completing a CITM module that required ultrasound competencies, and the faculty felt that they were achieving the images independently. Next slide, please. We developed a competency framework to support structured learning, and we encourage residents to maintain a log of the cases that they scanned. And we also provided remote support whether they needed any further advice or training. The theoretical session focused on the ultrasound scanning technique, as well as national and regional guidelines, and as well as Katie mentioned, how to use the QUIP app and interpret the results and formulate a management plan. We thought the ultrasound scanning technique was standardized, and we emphasized the clear mandatory anatomical landmarks that we needed them to obtain, and we have given them video demonstrations as well as a review of ultrasound images with common pitfalls, and as well as additional findings that may be found on ultrasound scans. Next slide, please. We were very pleased to see a marked improvement in theoretical knowledge after the course, as well as resident doctors moving from requiring direct supervision to indirect supervision. And we noticed that they reported that they had gained adequate exposure in recognizing optimal images and mandatory anatomical landmarks. Next slide, please. The self-reported practical ability also improved substantially, and we can see a clear shift from low confidence to great confidence, with mean self-rating scores increasing from 2.2 to 3.8 following the course.
It was really important to us that to make this training the most useful for our doctors, to have them scan real pregnant women. So we decided, what we've realised now is a little bit of a radical approach, to ask volunteers to come along and have this scan. Some of our participants were, if they were already coming for a screening scan, they were asked whether they would be happy to move to this training day with a full explanation and consent, and quite a lot of them were very happy to do that. And then we asked our trust to put out a communication on Facebook and on the trust website, and that was really, really successful. And we were fed back that the recruitment for the September date reached over 53,000 people on social media, and I'm not sure what the recent ones have got, but that was in September, and I think it's sort of even more popular since then. Anecdotally, we've had my cousin was pregnant, for example, and she had this disseminated in her NCT group and antenatal classes as well, so it sort of got shared via word of mouth as well. So they would email the preterm team email, and I would then phone each volunteer and fully explain what we were doing, why we were doing it, the procedure, and check they were very happy to come along. We offered a female chaperone for every scan. This was normally declined, mainly I think because 3 out of 4 of our specialists were female. So it was mainly just for the male consultant that a female chaperone was accepted. We also sent the participants a questionnaire before they came along, and this was demographic data, whether they had any risk factors for preterm birth. But most importantly, I wanted to make sure that we were aware if there was any sort of sensitivity that we need to be aware of, previous sexual assault, previous experience which might make a transvaginal scan difficult, and also whether they would consent to a male being in the room. And then this was flagged and colour coded on our clinic sheet as well. So we've had a really great number volunteering for each session. We had, as you can see at the table, 48 confirmed for the first day and 46 came, 42 for the second, 48 for the third, and I'm still recruiting. I've still got a few people to contact. Our next day is on Sunday, and we've got 39 confirmed for this week. These are the statistics that came out of our pre-course questionnaire for the participants. As you can see, mostly we had white British women volunteering for this scan. That is quite reflective of the demographic population we have in Oxford, and most of these participants were Oxford based. I don't actually have the data for the Stoke Mandeville day yet, so it'll be interesting to see how that changes when we've got our 2 days in Stoke Mandeville done. Most of these women had no known risk factors for preterm birth, but very interesting, a lot of these women were IVF pregnancies, and having spoken to them when counselling them for this scan on the phone, they shared with me that this was because they were familiar with transvaginal scans. It wasn't something that they were concerned about because they'd experienced it before, but also they might have had a slightly higher level of anxiety and wanted this additional scan as reassurance. It was important to us, knowing our demographic population in Oxford, that this opportunity was available to as many people as possible. So that's the English version of the poster we used for recruitment, but we had this translated into the top 5 languages, both in Oxfordshire and in Buckinghamshire, just to make sure that this was accessible to as many people as possible. And this was disseminated via our community team leads, our equality, diversity and inclusivity leads, in waiting rooms and lifts, and also on our social media.
So I'm just going to take you through some feedback we've had from some external critical peer reviews. I was in London at a preterm birth conference, and I met Manju from Consultant Obstetrician at Guy's and Tommy's, and we were talking about the concept and the idea at the time. And then with the funding and having the fantastic faculty that we've had, Manju came along as an external critical friend And she was just really loved the day, really impressed with the quality of the teaching and education, and absolutely could not believe that it was possible to recruit pregnant volunteers to be part of this program. She was thinking of using a simulator. So she's given us some amazing feedback, but one of the important things that she's taken away from it is she went and persuaded her team in South London HIN to give her some funding. And she plans on rolling out this program across her area. And she's very keen that we would try and consider how we might scale this up. And then at one of our most recent days, Sonali, who's a consultant obstetrician and gynecologist at Frimley Health, she came along as well as an observer, and her quote around the exceptionally well structured with the training delivered by an outstanding team. And again, at Frimley Health, so that is also the KSS Deanery. Wexham is in Thames Valley. They're determined to cascade the training across their trusts. We had some fantastic feedback from our volunteers. Really important to us that the pregnant women and people who came and offered their services for the day had a really good experience, and we were very keen to hear from them. So we've had some, you can see there on the right, Irina, one of our Romanian volunteers. So she gave us some lovely feedback and was, quite happy to go and talk to her own community about this opportunity for further when we planned our additional days. And Sanzaya, again, she really thought the day was very well structured. She felt comfortable and confident. So we felt very happy that we pitched it at the right level. And the next steps for this program are that we have got education and training days. We've got 3 more, 2 at Oxford and 1 at Stoke Mandeville in Buckinghamshire. Maria's going to lead on the project evaluation and write-up. And we were very keen to have further opportunities to present and share the learning from this work. And we plan to follow up with our trusts and see how they're managing with the cascading of the programme locally. And I've put our contact details here. If anybody wants to email us or get in touch with us, very welcome to come. And if you've got a particular interest in something like this, you can talk to us about coming maybe to observe the actual training. And thank you for your time. I'm going to stop sharing now. Is that all right, Sian?
Yes, thank you. Thanks, Sally. And thank you, Maria and Katie as well. That was very interesting. Hands up for questions. First off the bat is Rachel. Do you have your hands up, Rachel?
Sorry, Sian, I was trying to give Eileen a lovely clap. And I'm sorry, I put my hand
No
up
problem.
instead.
Thank you. So I've got one question, and I wasn't sure if you'd actually gone down this route or not. Did you involve your MNVPs in the trust in asking for volunteers and getting them involved in it? Katie, do you know?
So we had the amazing help of one of our parent. What do you? It's Emma, isn't it? And
yes, Emma Johnson.
I can't remember her official title.
PAG. Yes.
Yeah. She was absolutely incredible. She helped us design the posters. She helped us do the participant questionnaire. She was so useful.
Brilliant. Thanks. I just think, just in case it was an untapped resource for you.
No.
Thanks. Any more questions?
I mean, I think we're very conscious that the co-production side of it is it's just an important element in all projects that that you're trying to facilitate. So, yes, Holly. Hi.
Well done, Eileen. It's a great
Thank
project
you.
to hear about. I'm sorry if I missed it, so just bear with me. Were you just training within Oxford, or were you training clinicians from other trusts?
Maria, do you want to take this?
So we trained resident doctors who are working across Thames Valley region. So that involves multiple trusts within the region. And then we had, as Aileen mentioned, we had external consultants, senior consultants who were interested in observing the sessions, who also attended the educational sessions.
Thank you. Did you have any issues with doctors working or doing sort of clinical training in a trust that they weren't employed within?
That's a very good question, and because because these are doctors who are in training, they were allowed to come and scan without needing any additional approvals as such, because it was part of their training program. And also we offered to complete formal assessments for their e-portfolio to demonstrate that they participated in this learning event. Eileen will talk about the aspect of like the faculty having we needed to get honorary contracts so that we can so that's a different side, but for resident doctors we didn't need any extra approvals because those were covered by the training program scheme.
Okay. But
So for
honorary contracts for your faculty.
Honestly, and
Yes.
Definitely something, if there's a, something you wanted to take this program forward in the Wessex region, you need to start early, because the process for appointing honorary contracts for doctors, it's straightforward, but it is slow, and it requires some paperwork and some, immunization records, for example, and those are not always readily available. I was quite surprised, but it is perfectly possible, and I would encourage. I wouldn't consider it to be, something that would block a project, but you do need to start early.
Well done with your perseverance, because it's always barriers to that sort of stuff. So well done.
Absolutely. So, I mean, I think I would be quite keen in the group that are here today, if there are interested consultants or, preterm specialist midwives who would be interested. I appreciate that traveling might be a bit of an issue, but we'd be very welcome to have, people come and observe the day, because I think that makes it really kind of real, and then you sort of inspires people to think that they might be able to do something like this, because it's really important to scale this up. There is an absolute gap in the training and education for the resident doctors. Katie, go ahead.
I was just going to say, with training lots of people from different hospitals as well, we did make it very clear with each hospital before we started that the consultants in their home unit would be responsible for ongoing training if that was required, and making sure that they were happy personally with the fact that they were happy to sign their doctors off as competent to go ahead and do that in practice. We are really careful not to say, oh, we're happy with you in Oxford, you can go back and do this in Milton Keynes. That's Milton Keynes, that's their responsibility, that ongoing training is their responsibility, and cascading that locally as well. So we did sort of, before any of this, we did an agreement, didn't we, across the network,
yes.
Eileen? Yeah.
Yes, we did, yes. And we had, the other thing I think to note is the safety and governance for the pregnant volunteers. So if a pregnant person from, say, Buckinghamshire saw the opportunity and wanted to come along to an Oxford day, we then had to make sure that we had safety and governance in place, so that when she returned to her booking trust, that any interventions that were necessary were able to be kind of managed by that trust. Charlotte.
Oh, thanks, Eileen. Fantastic project, and thank you for coming to present, you and the team. I was just thinking about the the volunteers who put themselves forward for this. And you said the majority didn't have any risk factors for preterm birth. Did you have kind of any incidental findings or pick up any women who would be more likely to experience preterm birth?
I think the only ones we picked up with a short cervix were the women with risk factors. We've been very fortunate so far, touch wood, not to pick up too many short cervixes. So I think we've had 2 maybe from the first day, 1 from the second, and in Stoke Mandeville, I think there were a few women who were part of their high risk preterm birth cohort. So they had follow up and interventions implemented locally.
Brilliant, thank you.
Right.
I think it's really important to factor that in, because it can have an impact on how you run the session. So we have additional backup plan if we were to identify a woman that would need preterm birth prophylactic interventions or further counselling. We had a room and a dedicated clinician available to take that forward, so that we can continue to run the session as planned and be in keeping with the timings and the scanning time.
And it's obviously eliciting a lot of interest. If you've seen in the chat, Eileen and Maria,
no.
Sean from Ashford St Peterson's is keen to come and observe a session. So if you want to get in touch.
Great. I'll follow. I mean, I'll go through the chat in a minute. I was too busy paying attention to what was going on here. But I'll follow up. Anybody in the chat who wants to get in touch, I'll follow it all up with you guys. We've got 3 more dates. So hopefully that should be helpful for people.
Brilliant. A lot of interest there. Thank you to all 3 of you. Really
thanks for having us. Yeah, thanks for having us.
Thank you. Right, and we're on to our last session of the day. This is a recording because unfortunately Stephanie wasn't able to make it today, but she's going to be talking about the genetic risk equity project they've been undertaking in Frimley. Thanks, Charlotte.
Hi, my name's Stephanie Holloway and I'm the Genetic Risk Equity Midwife at Wexham Park Hospital. Sorry that I can't join you live today. I'll put my email address at the end of the presentation so that if anyone has any burning questions, you can send them my way and I'll do my best to answer them. The Genetic Risk Equity Project was previously known as the Close Relative Marriage and Culturally Competent Genetic Services Project, but the name has been changed in the last couple of months, I think, partly to make it less of a mouthful and partly in response to some of the recent negative press around close relative marriage. But in its current form, the focus still is on marriages between close relatives, also known as consanguineous marriages, and particularly amongst families of Pakistani origin, because that is the demographic that primarily practices close relative marriage in the UK. So it's a national project, a pilot project that was started in 2022 as part of the NHS's genomic strategy. The project came about on the background of consistently raised mortality and morbidity for Black, Asian and mixed ethnic groups. As we know from the Embrace reports, this demographic experiences consistently higher rates of morbidity and mortality during pregnancy, birth and the postnatal and neonatal periods. So the genetic risk associated with consanguinity was one of 4 areas that were highlighted as an opportunity to try and reduce some of this inequity. 10 geographic areas were identified across England that felt they would benefit from a targeted intervention in the field of genetic risk equity. And Slough was approved to join the project in 2023, which is when I came on board. I operate out of the Wexham Park site where we book around 350 women a month, and of those about 20 or 25 will be in a consanguineous partnership, so around 6.5 or 7%. Most of those women are of Pakistani origin, but we're slightly different from the other high need areas in that we also have a significant Irish traveller population in Slough who also commonly practice marriage between relatives. The reason for the focus on consanguinity and particularly consanguineous Pakistani couples is that they are disproportionately affected by severe recessive disorders. So as you all probably know, we all carry some faulty genes, and being related to your partner doesn't mean that you carry more faults, it doesn't mean that you carry more severe faults, but it means it's more likely that you and your partner will carry the same faults. So consanguineous couples are at no greater risk of dominant or X-linked disorders. They're at no greater risk of chromosomal disorders like Down syndrome, but they are at a greater risk of recessive conditions. In the UK, about 2,300 children are born every year with a severe recessive disorder, and almost a third of these are from parents of Pakistani origin. Bearing in mind that British Pakistanis only account for about 3 to 4% of the UK population, that's a massive over-representation in this data. And the impact on those families of having a seriously unwell child can't be overstated. And of course, there's a knock-on impact on NHS services also. Because of the way that recessive conditions are inherited, they tend to cluster in families. So you might have heard a figure being quoted in some of the recent discussions about cousin marriage, that the background chance of having a child with a congenital anomaly, if the parents are unrelated, is 3%. And if the parents are first cousins, then that chance doubles to 6%. So the vast majority of children born to consanguineous parents will be healthy, but that 6% figure is an average across consanguineous couples. And in a family where there is a genetic condition, whether it's known or unknown, that chance can be as high as 25%, which is why those couples and their wider families can really benefit from targeted genetic counselling. Unfortunately, the referral rates for British Pakistani couples into genetic services are very low. Every consanguineous couple doesn't need to see a geneticist if their wider family is fit and well, but if they have a family history that is suggestive of a genetic condition, maybe there's lots of people with learning difficulties, or there've been an unusual number of stillbirths or unexplained deaths in childhood, if there have been babies born with congenital anomalies, those families might really benefit from some input from clinical genetics. But fewer than half of the Pakistani women who fit the criteria for a referral nationally are being referred. And when they are, then they often face linguistic or cultural barriers that can make it difficult for them to understand the information that they're given. So the aim of this project is to improve access to genomic services for British Pakistani families in particular, and to give them the chance to make informed reproductive decisions. Any family who presents to maternity services with a known or a suspected history of a genetic condition should, of course, be offered a referral to clinical genetics, but we know that consanguineous British Pakistani families have historically been underserved by genetic services, and that they face greater barriers to accessing those services. So the purpose of the project is to try and redress that balance. Some of the barriers, genetics is such a complex topic and one that's being explored relatively recently compared to other concepts in healthcare. So understanding can be quite poor across all ethnic groups. But for the Pakistani population in the UK, it can be especially difficult because of the language barrier. So even if you have a great translator who can translate the words for recessive and chromosome and gene, the average person might not really understand what you're talking about. Then genetic explanations for ill health might clash with people's existing beliefs. So disabilities might be attributed to black magic, to God's will. Some people believe that inherited conditions are passed down through the father's line, not the mother's. So when they're making reproductive choices or choosing a spouse, they don't take into account conditions on the maternal side. Then in some Pakistani families, the family system can mean that women don't necessarily approach decision making in the same way that a white British person might. So decisions are more often made as a family, or at least the family's opinion is given a lot of weight. So if the couple's family is strongly opposed to them pursuing genetic testing, then that can be really prohibitive to them pursuing it. The flip side of that is that when the family is open to genetic testing, then those family links can also act as channels of information. So we've had cases where we referred a woman for genetic testing, and during that process, she then revealed that her sister is about to get engaged or is recently married to a cousin, and that her sister would also like genetic testing. So so that can be kind of a barrier or a benefit, as it were. Many ethnic minority groups exhibit a distrust in the healthcare system. They might have previously experienced stigma, they might have a poor understanding of what genetics involves. People have expressed concern about what we might do with their child's DNA. Are we doing experiments on their child's DNA? They might not be aware of what care is available or how to access it. And then there are also flaws sometimes in the way that we deliver the care. So midwives report feeling uncomfortable asking about consanguinity. They might just ask, is everyone in your family fit and well? Instead of taking a really good family history. Or they might not know how to refer. They might assume that somebody else has made the referral. So GPs who've engaged with this project have said, we sort of deal with the coughs and the colds and the problem that's in front of us. But if the child's under a paediatrician, genetics is kind of the paediatrician's remit. and it can become anybody else's job. Then there are also some persistent misconceptions that can hamper conversations about reproductive options. So many people assume that Islam forbids termination of pregnancy, and that therefore there's no point in having conversations about serious fetal conditions. But there's a fairly well established school of thought amongst Islamic scholars that a termination is permissible within 120 days of conception. That's about 17 weeks, excuse me, for serious medical conditions. So time is of the essence when we're making those referrals. Some women, of course, won't consider a termination at any point, and some would consider one after those 120 days. But many women are aware of this 120-day kind of limit, and so for them there's not a huge window of time in which to make the referral to genetics, have them counsel the couple, carry out the test, and for the results to come back. And also the point of the exercise isn't to increase the number of women terminating their unwell pregnancies, it's to give women the information to allow them to make whatever choice is right for them. And knowing that your family carries a particular genetic variant or a particular condition can open the door to options like targeted IVF in a future pregnancy, or it can inform conversations with other family members who are considering marriage or pregnancy, or it can enable prenatal diagnosis of a condition so that as soon as the child is born, the family can put things in place to manage that diagnosis. So some recessive conditions, if treatment is started within hours of the birth, can have a relatively mild impact on the child's quality of life. But if that window is missed and treatment is started later, then the condition can have a really significant impact. So it's really important to try and overcome some of these barriers. Part of my role is informal training and support for midwives to identify families at an increased risk of a recessive condition. And the main message I try and get across is the importance of taking a really good family history at the booking appointment. So every couple, regardless of their ethnic background, should be asked about consanguinity, just in the form of, are you and your partner blood relatives? And then it can feel quite probing, I think, to ask specific questions about families' medical backgrounds, but it's not enough to ask, is everyone in your family fit and well? Or does anyone have any medical conditions? Or even does anyone have any genetic conditions? Because very often the information that the women have about their family members can be quite non-specific. And everyone has a different understanding of being fit and well. So a person might be in a wheelchair, on oxygen, but they're living well with their condition. So I try to encourage the midwives to ask really specific questions about genomic red flags. So have any children in the family been stillborn? Are there children who have died? Does anybody need help with the daily tasks of life, washing, taking care of themselves, communicating? Are there children with learning disabilities? Are there children who see a doctor regularly? I just try and encourage the midwives to get as much information that they can as they can at the first appointment, and to use medical interpreters where that's needed. Then if the midwife suspects a genetic condition, they refer the woman to me and I contact her to take a more in-depth history. I might try and obtain copies of previous medical records, and I'll offer them a referral to our local genetics service, which is based in Oxford, and talk them through what that referral kind of will look like. Then the geneticists in Oxford do the actual genetic counselling and determine what types of testing might be appropriate for that family. They'll discuss the results of the testing and the implications of those results. And then if there's any follow-up required as part of the maternity care, then I can arrange that locally in Wexham. I also audit the notes of any couple who has answered yes to the question, are you and your partner blood relatives? To see if there's anything documented either in this pregnancy or in any previous care that makes me think there might be an underlying genetic condition present. and then I'll contact her to discuss that, even if the booking midwife hasn't referred her to me. And then I attend a monthly MDT meeting between the obstetrics and neonatal departments in the hospital, so that if there are specific plans that need to be put in place around the pregnancy or the first days and weeks of the baby's life, then those can be arranged and documented in the notes. And then the midwives on the labour and postnatal wards are aware of those, so that they can ensure, for example, if blood needs to be taken from the umbilical cord for testing, or if the baby needs particular paediatric input soon after the birth, then they can be sure that that gets done. So just to finish, I've got a couple of case studies. So in this case, the couple were first cousins. They were having their second baby. The parents told their community midwife at the booking appointment that their first child had been born in Pakistan and had sadly died shortly after birth. And the parents were told that this was due to Dandy-Walker syndrome, which is a genetic condition that occurs sporadically. It doesn't tend to be inherited. So the community midwife referred the couple to me. I contacted the parents. I discussed their history. They sent me a copy of their maternity notes from Pakistan, which was really helpful. And I saw that the diagnosis of Dandy-Walker syndrome had been based on the child's clinical presentation, but the parents hadn't had any genetic testing to confirm that. So I offered them a referral to genetics here, which they accepted, and the geneticist ran a test on the parents' blood samples that looks for about 300 known fatal recessive disorders. And this testing revealed that both parents were carriers of a particular genetic mutation which presents similarly to Dandy-Walker syndrome, but it's a recessive condition. So each of their pregnancies will have a 25% chance of being affected, and that's quite different from the information that they were originally given, that it wasn't an inherited condition. So the parents opted for diagnostic testing of their unborn child in the pregnancy, and it was found that this baby also was affected by the same condition. So they made the difficult decision to terminate the pregnancy. And that could so easily have been missed if we had taken the Dandy-Walker diagnosis at face value, and the parents wouldn't have had the opportunity to make the decisions that were right for them. So the second case, the parents were also first cousins. One parent had a known what's called a CACT deficiency, and the other parent was a known carrier of the same. So that's a condition that prevents the body from using certain fats for energy, and it's associated with kind of multi-systemic symptoms that affect different organs throughout the body. It's quite an unpleasant condition. If it's not diagnosed early, many babies don't survive the first kind of weeks of life, partly because the fat content in both breast milk and in most infant formula is dangerously high for them. So the parents were offered a choice of either in utero diagnosis of their baby using samples taken from the amniotic fluid or the placenta, or of postnatal diagnosis using a blood sample that would be taken from the umbilical cord at the time of the birth. So they opted to have the postnatal diagnosis done immediately after the birth, because they felt that they were committed to continuing the pregnancy, and having a diagnosis antenatally wouldn't really add anything for them. So during the remainder of the pregnancy, we were able to arrange a multidisciplinary plan between the maternity and neonatal units at Wexham Park, with input from the metabolic dietitians at Great Ormond Street, so that the parents could have a feeding plan in place ready for the birth and for the first few days of life while they awaited the results from the cord bloods. And we were able to make sure that we had stocks of an appropriate specialist formula on the ward for them. Forward, although the ring-fenced funding from NHS England for this pilot project will come to an end in the spring of next year, genomics and equity both remain areas of priority within maternity services and across the NHS. So the national evaluation of this project will be released later this year. And in the meantime, at Wexham Park, we are looking at how best to ensure that the changes that we've made to our clinical practice as a result of this project are sustainable, and how to continue embedding that learning and embedding an equitable genomic strategy into our maternity service. And we'll know more about exactly what that looks like in the new year.
Okay.
As I said, if anybody does have any burning questions, then please feel free to email me, and I will do my best to answer them. Okay, thank you.
I hope you all enjoyed that presentation by Stephanie. As she said, she's very happy to take questions from anybody. If you'd like to put anything in the chat, or we can pass them on to Stephanie at a later date, or you can contact her directly. Personally, I found that fascinating. Okay, thank you all for attending today. That's the end of our presenters.
Hi, my name's...
And I feel today we've had a really great range of presentations, and I'd really like to thank all the presenters today for keeping us entertained and aware and informed over the last hour and a half. I think the importance of World Prematurity Day in raising awareness and being able to thank staff and remember the people who've been affected by it is really important. We've got a fascinating insight into smoking in the southeast and the impact of inequalities on practice. The invaluable work that's been done to train staff to be aware of and understand the cultural factors in the patients that they're caring for. And the really innovative approach to the cervical scanning project pilot, which was great to how you involved women. I think that was brilliant. And I'm sure that's going to garner a lot of interest across the whole patch from people who've been listening today and spread. So be great to be updated later on about what happens and the outcome of that project. I'm sure everybody would welcome that. And also learning about the very specific service available for patients within the Slough area and the intricacies of supporting those people undertaking pregnancies. So I'd like to ask you all, if it's possible, I hope you enjoyed today's webinar. And again, thank you to all our wonderful speakers. I'll be really grateful if you could complete the feedback form, just to let us know what you think of the webinars and so that we can fine-tune them to what you need. And the QR code is there for you to do it, and also the link is on the slide, but we'll be sending it out in the slides, and they'll also be uploaded onto our Futures platform and our website. So we've got a couple of minutes left, so time for you to pop out and get another cup of tea, if that's all for today. And can I just say a big thank you to everyone for attending today, and hope to see you at our next webinar, which will be in January. Okay. Look forward to seeing you all. Thank you for coming.
Thank you.